Welcome to Fertility Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining.
Hi, everyone. Welcome back to Fertility Village Live. I'm Joy, and I'm so glad you're here with us today. We have a very special episode for you tonight.
I'm Marissa, and since September's PCOS Awareness Month, we wanted to dedicate today's conversation to one of the most common, but also one of the most misunderstood conditions in reproductive health, which is PCOS, known as polycystic ovarian syndrome.
PCOS can impact not just fertility, but also metabolic health, hormones, and even emotional well-being. There are so many myths and so much confusion out there, and we have the perfect guest for you to unpack it all.
So we're thrilled to be joined by the one and only Dr. Prati Sharma. She's a leading fertility specialist who is here to unpack the basics of PCOS, answer some of your questions, talk through the latest treatments and fertility options. So Dr. Sharma, thank you so much for being here today. Please tell us a little bit about yourself. I don't know if we'll have time because I don't know how you do everything you do with whatever time you have. You do so much, but tell us a bit about yourself, the work that you do with PCOS patients, the work that you do in general, all the things that you're on. I want a little bit of what you have energy-wise per day, I think.
You're too kind. You really are too kind.
So much accomplished if I had your energy.
Oh, please. No, thank you so much. I love the intro, by the way. Like, I'm going to come on every Wednesday now to listen to you guys. It's great and very catchy. So thank you so much for having me on the show. And you're absolutely right. September is PCOS Awareness Month, and you guys are like right on it. You're the first event that I'm doing. So you've really got your pulse on what this month is about. So yes, I'm Dr. Prati Sharma. I'm a fertility specialist. I've been practicing in Toronto for over 15 years at Create Fertility Center. I trained in New York and moved to Canada after my fellowship and started my practice. So yeah, PCOS is right up there with like the top 5 things that you expect to see in a fertility clinic, if anyone were to ask you. And it is one of my interests for many reasons. One of the big reasons is I'm South Asian, and it affects the South Asian community much more than other communities. So I probably was someone who was living with PCOS most of my reproductive age life. And, when you talk about misunderstandings and myths, like, it's one of those things where you're just like, oh, this is just me and I have to live with this. And that's not necessarily true. So I'm sure we'll unpack a lot of that in this talk, but a little bit more about me. I am the incoming president of the Canadian Fertility and Andrology Society. I'm an advisor for a couple of really cool femtech companies, Bird and Bee, Future Fertility, and a new one called My Fertility Labs out of Alberta. Initially, early on in my career, I developed a sort of web-based informational website for patients who were sort of looking for digestible information about fertility called the Conception Diaries. I'm also on the advisory board for Carrot Fertility, which is a third-party payer for fertility benefits. And I try to be an advocate for patients providing like really easy to understand evidence-based information on social media, because we all know that's where we find our information. And, Dr. Google and social media can have a lot of good things, but also a lot of bad information. So I try to break that down for patients. My clinical practice is like from A to Z of reproductive medicine, whether it's I just want to pulse on my fertility just to see where I'm at, or I've gone to 5 clinics and failed 5 IVF cycles and I need a 6th opinion. I kind of see from A to Z. I welcome any new patients. So if anyone is on this webinar and would like to see me, happy to give you an in to sort of beat the wait list in the line and come see me soon so we can talk about your fertility. But I don't want to hold up the important discussion any longer. We can get started.
But do you see what I mean? Look at all the stuff that you do.
I think if I wasn't busy, I would feel like something's wrong with me. So, you know, I'm like the Energizer Bunny. It would be weird for me to just sit idle.
Okay, so let's start with the basics. Could you give us a quick overview of what PCOS actually is and why it can be so tricky to diagnose?
Well, let's start out with the name. So PCOS, or polycystic ovary syndrome, like if you were to look at that name, you would think, oh, I have lots of cysts in my ovary. And that's actually completely not true. I feel like maybe even in my lifetime of caring for fertility patients, that name might be changed because it's such a misnomer. The diagnosis of PCOS is a clinical one, and you have to have 2 out of 3 of the following criteria. One is polycystic appearing ovaries on ultrasound. But when we say polycystic ovaries, it's actually the presence of 12 or more follicles that are 5 to 10 millimeters that surround the periphery of the ovary with an increase in this central stroma. So it's a very particular ultrasound characteristic. We call it the string of pearls appearance. So you have these like little black circles or follicles and tons of them on the outside skin of the ovary, let's say, and the middle of the ovary is this white area that produces all the male hormones. So those are what polycystic ovaries are. They're actually not cysts at all. They're ovarian follicles that have the eggs on them. But the interesting thing is a lot of women have polycystic ovaries, but don't have polycystic ovary syndrome. I was actually talking to a patient today who has polycystic ovaries, but has nothing else to say she has the syndrome. So the second 2 criteria are clinical or laboratory signs of high male hormones. And laboratory signs are so hard. Even in like profound PCOS patients, you check their male hormone levels and they're like maybe a little bit elevated. So some people actually favor not even checking male hormone levels because they don't provide so much additional information, but it's really become part of our diagnostic criteria. So we just do it. But it's really the clinical signs of high male hormones. And what are those? Acne and facial hair are the big ones. Difficulty losing weight. I can't tell you how many times I hear patients say, I try to lose weight. I exercise 30 minutes a day, every day, 7 days a week. I do caloric restriction and I just keep gaining weight. And that is a classic sign of hyperandrogenism. So I also used to always think early on in my career, it's excess facial hair. It is excess facial hair and acne, but hair loss is also a sign of PCOS. So a lot of women have like male pattern balding. So they like lose hair up here. They have hair thinning. So that's also a sign of hyperandrogenism. And the third is irregular cycles. You cannot have perfectly regular cycles and have PCOS, the syndrome. You might be a little PCO, which means you have the polycystic ovaries, but if you have perfectly regular cycles, you don't have the ovulatory dysfunction. So the ovulatory dysfunction comes from the irregular cycles that are typically more than 35 days apart. And that can range from someone who's every 35 to 40 days, which is quite classic in the PCOs who are maybe like me, skinny PCOs, where their cycles are just a little bit longer. Or you could have no cycles whatsoever, chronic anovulation or amenorrhea. So those are the 3 criteria, and you need to have 2 out of the 3, classically the hyperandrogenism and the irregular cycles. Now, a 4th piece of this is insulin resistance. And so a lot of PCOS patients will have impaired glucose tolerance, early diabetes, even diabetes. But in the ones who are like, you know, all of us who are very in tune with wellness and health and normalizing their BMI, you might not see classic insulin resistance, but in their blood work, they'll have somewhat high insulin levels or borderline sugar levels. And so you have to have like a really intuitive eye for it.
Wow. I think I have PCOS and I've learned more about PCOS in this few minutes of you chatting than like I've ever known about PCOS. It makes so much sense now.
You learn a lot when you listen to patients. And when you hear the patients with PCOS saying the same classic things, you're like, yeah, this is really what it is, you know, real talk. Like,
and so why do you think PCOS is often underdiagnosed or misdiagnosed, or people will come out saying, I have PCOS, but they have polycystic ovaries and not.
Yeah. So I feel like it's overdiagnosed or underdiagnosed sometimes. So I think, and God bless family doctors, they're really great. But when they see young patients and they do an ultrasound on them, because that's like, oh, you want fertility help? Do an ultrasound. And the ultrasound comes back and it's read by a radiologist who's not like thinking fertility. And they say PCOS ovaries, which happens a lot on ultrasound. Often the primary care docs will say, oh, you have PCOS, without like looking into all the other criteria. So those patients I find, yes, some of them are PCO, but some of them are just PCOS-ish, meaning they're young with high fertility, but they don't have the whole syndrome. When we look at why it's underdiagnosed, well, we know that women in their like teen and late teen and maybe even early 20s are going to have irregular cycles. Like your body is sort of just getting used to menstruation and things like that. But sometimes that cycle irregularity continues and people just normalize it. They're like, that's just me. I'm every 40 days, or I get a period every 2 months. Like I tend to, even now, still see patients only when they're trying to conceive. And they're like, yeah, now I'm trying to conceive and my periods are 6 months apart. And I'm like, wow, it didn't bother you at all that it was 6 months apart for like 10 years of your life. It's only when they're trying to conceive. So I think people just underestimate the importance of cycle regularity. In this day and age, there's so many ways to manage things like hyperandrogenic symptoms like acne. You take Accutane. Like how many teens and young 20-year-olds take Accutane or Retin-A or whatnot, just because they want to deal with their acne and look good, right? Or if they have excess facial hair, there's waxing, there's electrolysis, there's all that, and there's ways to control it, right? Yeah. So they just kind of deal with it. The other thing in certain ethnicities, I'll speak about the South Asian population, is that we're used to hair. So it's pretty normal. And so we go to the threading salon and take care of it, right? And that's just considered normal. So I think it really only comes out sometimes when you're trying to conceive. That being said, things are changing. And now I'm seeing a lot of women for management of PCOS. And it's great because then they get in early. They kind of can take care of it, deal with it, sort of treat it. And when we come to treatment, we'll talk about that. There's sort of a couple different phases. I see PCOS as the young patients who are not trying to conceive and they need to regulate their cycles and their hormones. Then there's the middle phase of patients who are trying to conceive and you need to get them to ovulate and get pregnant. Then there's I've had my babies, but now I have a little bit of excess body fat and, I'm busy, so I don't exercise enough and I have prediabetes and the whole metabolic syndrome. So there's 3 phases. So it's nice that I can catch people now in the first phase and get them ready for phase 2.
Yeah.
So are there different types of presentations for PCOS, and what are the most common signs and symptoms that you see?
Yeah. And so I would say there's really 2 major groups of PCOS, although PCOS is a spectrum. So you can have patients who have all kinds of symptoms that range from the lean PCOS patient who literally you couldn't tell she was PCO if you looked at her. Thin, low BMI, no facial hair or acne, but really irregular cycles and high LH levels. LH is luteinizing hormone. That's the hormone that drives male hormone production in the ovary. And so PCOS patients often have high LH levels. And those patients are actually really tricky because they come in and they're often given the diagnosis of PCOS, but there's a parallel to PCOS called functional hypothalamic amenorrhea, or FHA. And so that really mimics the lean PCOS syndrome. These are women who, think of the runners, the gymnasts, the anorexic patients. Those patients have such a low body weight that they can't support ovulation and menses. And their ovaries are also robust and beautiful and have lots of follicles. So those 2 types of patients look very similar, but you have to look at the history. So the lean PCOS patient probably has a little bit of the hyperandrogen symptoms. They have high LH levels as opposed to low LH levels, and history, like the patient who had a previous history of anorexia or exercise a lot or was a runner in the past or a figure skater. Those are more the FHAs, and they need FSH and LH. Their LH levels are low as opposed to PCO. So the lean PCOS classically does not look PCO. And then the opposite of the end of the spectrum is the classic, what we call Stein-Leventhal syndrome, or classic anovulatory PCOS. That's if you open a textbook and you looked up PCOS in the index in an REI textbook, you'd open it and you'd see a picture of what we used to call, like, again, this is probably like very faux pas, but historically it was the bearded woman. And so this is the obese patient that has tons of facial hair, has something called acanthosis nigricans, which is a darkening of the skin in the underarms and the skin folds. So that's like the classic PCOS who has severe insulin resistance, high A1C, doesn't ovulate, has like high BMI, can't lose the weight. And those patients, you'll often even see the serum levels of high androgens. But I'll tell you, in clinical practice, most patients are in between. So not the acanthosis nigricans, bearded women sort of PCO, and not the classic lean PCOS that doesn't get cycles and you can't really tell. They're all kind of in the middle. So these patients come in and you really have to kind of ask, you have to be like, so have you ever struggled with facial hair? Did you have acne? Because they'll be like, yeah, but I laser it. Or yeah, but I see a dermatologist and I use topical acne medication. And yeah, I have to work out a lot to even lose 5 pounds. So most patients are in that middle area. And so I think I've covered the different presentations and the different symptoms.
Yeah. And now the biggest question that everybody probably wants to know, how can you manage it? What can you do? So I take Bird & Bee, like inositol every day. Yeah. Their little supplement that you just put in.
Yeah. You find it helps?
It's helping a lot. Like, it's making a massive difference. And I think there's 2 types of inositols in there, whereas before I was only taking one inositol. What else can you do to help? How can you manage PCOS on a day-to-day without having to do like the electrolysis and the acne medication, just get to the root of the problem?
Yeah. And so, I mean, I talk a lot these days about lifestyle management and supplements.
Okay.
We're so medically oriented. And I'll tell you, when I trained in my fellowship, it would be like, you see a PCOS patient that doesn't want to conceive and you put them on birth control pills and a medication called spironolactone. That was like bread and butter starting. And so birth control pills to regulate the cycles and also drop male hormones, cycle the patients so that they don't get endometrial hyperplasia because they need to bleed every month. And spironolactone is a diuretic and it's an anti-male hormone. And it's great for acne because the combination of birth control pills and spironolactone really drives the male hormone levels down and does wonders for acne cycle regulation and hyperandrogenism. I only mention that because that used to be like the starting first line. But now we have, like you said, Marissa, this whole like lifestyle supplement area, which is so much better tolerated and you feel so much better about yourself because you're actually doing things to help and to maintain, right? So yes, inositol is like a newer supplement. It like nobody knows its true mechanism of action. And actually we're talking about doing a study through Bird & Bee about, symptom relief and mechanism of action. But the thought is that it somehow reduces male hormone levels and reduces insulin resistance and stimulation of the ovary to produce androgens. So it's a great supplement to help mitigate the symptoms of high male hormones. And probably it also affects insulin resistance, which also helps that. And maybe somewhat plays a role in cycle regulation. Cycle regulation is tricky. Like for that, I always say in terms of lesser means and lifestyle, even losing 5% of your body weight, so like 5 pounds or 10 pounds can help regulate your cycles because excess body fat makes insulin and insulin drives the cycle irregularities because it makes more male hormones. So if you can get into a diet and exercise program and lose weight, obviously if you're not a totally lean PCO, if you could, you have weight to lose, that'll help. Diet and nutrition are key in addition to supplements like the Bird & Bee supplements and inositol, like eating more protein, less processed food, reducing your sugar burden, like all of these things can really help. And so changing your lifestyle and diet are also really important. I always stress that to my PCOS patients. Then if you're not trying to conceive, definitely the mainstay is some sort of hormonal regulation of your menses. I like birth control pills because in addition to regulating your cycle, so you'll get a period every month or every 2 months, the act of the birth control pill itself increases something called sex hormone binding globulin. And it's exactly what it says. It basically sucks up all the extra testosterone and binds to this protein so that your male hormone levels go down. And so if things like acne are really bothering you, you can add on this medication called spironolactone, but you have to be careful not to get pregnant while on it. If you don't want to take the birth control pill, you can do something called cyclical Provera, which is getting yourself a period every couple months. And a lot of PCOS do that. They're like, oh, I haven't gotten a period in 3 months. I'll go to my family doc or the fertility doctor and induce a period. So that's the treatment if you're just trying to manage your symptoms, but you're not trying to conceive. If you're like ready to conceive, then you'd see a fertility doctor, certainly do all of the fertility testing to make sure sperm's normal, tubes are normal, uterus is normal, egg count is good. And then the mainstay of treatment is ovulation induction as a first step. And typically we use letrozole, which is an anti-estrogen, to ideally develop one follicle and induce ovulation, either paired with natural intercourse or IUI. If you're under 35, you can do that for up to 6 cycles before moving on to something more aggressive. And the one thing to remember is PCOS patients are very sensitive and they have a higher risk of multiples if you start going up high on dosages of fertility medications.
Wow.
And certainly we can go on to sort of category 3, which is like
somebody just commented, I take the powdered inositol from Bird and Bee. Is that also as effective as the capsule?
Absolutely. Absolutely. It's just as effective.
Yeah.
And it's probably much better tolerated because it's flavorless and you just put it into your drink.
I put it into everything. I put it into, well, I shouldn't be saying that. Sometimes when I have a Coca-Cola, I put it into my Coca-Cola. I put it into
I feel like that's good. Like it's like you can have the Coke, you had it with it. Perfect.
I put it into like my smoothies if I have an iced coffee or just water. Like it's completely flavorless, so it doesn't change the flavor of any of my beverages. So it's
cool.
Very easy to take. Yeah. Big fan.
That's great feedback.
Yeah.
Aside from inositol, are there any other supplements that are helpful in PCOS?
Yeah, I mean, that is really truly the big one. I mean, I think, there's a lot about inflammation out there, right? Inflammation and insulin resistance are probably really related. So in addition to inositol, a lot of even our Bird and Bee PCOS supplement or the Bird and Bee prenatal has a lot of antioxidants in it. So I think antioxidants definitely go hand in hand with inositol, especially because PCOS and eventually metabolic syndrome, which kind of includes high blood pressure, like syndrome X, all the things that people get as they get older and have insulin resistance, that's all associated with inflammation. So if you can do stuff to reduce your inflammation, that really helps. So things like probiotics to reduce gut inflammation, it all goes together.
Okay, very cool. Okay, so another question, which I guess the fertility community wants to know. What are the first steps someone with PCOS should take if they're trying to conceive and it's not working for them, trying without assistance?
Yeah. So, I mean, I would say the first thing is cycle tracking, right? Because obviously you need to ovulate in order to conceive. And so I always say to patients, like if you're getting periods once in 6 months, you don't need to wait a year. Like if you're 30 and historically you've gotten periods once in 6 months, you don't have to try for 6 months to a year. Like go direct, do not pass go to a fertility doctor because you're not ovulating, right? But then there's patients who are like every 28 to 35 days or 35 to 40 days. So for those patients who are young and want to give it a chance naturally, they can use a menstrual app or a cycle calendar and sort of clock out their cycles. And if they're routinely every 35 days, then your ovulation is going to happen 14 days before that 35-day mark. So you're ovulating on day 21. So now you're ovulating later than usual, and you can make sure that your fertile window is around day 20 to 23, and that's when you'd have intercourse. And trust me, a lot of people who are young get pregnant that way, and they don't need to see me. But if you're every 35 days and it's been 6 months and it's not working, definitely important to come in. The tricky part with ovulation predictor kits, which a lot of women do use to conceive, is that they are detecting the LH rise. And so the problem with women with PCOS is that they have baseline high LH levels. So what PCOS women often find, not always, but often find is that they're positive with their LH sticks like throughout the cycle. And they're like, I don't know when it's a surge and when it's not a surge, because they're constantly positive. So those things don't really help.
So, what fertility treatments are the most effective for PCOS patients? And in IVF, how does PCOS affect stimulation, and how do you keep patients safe from risks like OHSS?
Yeah, great question. I mean, I think that in an ideal world, every PCOS patient would get pregnant with just low dose ovulation induction and IUI or natural intercourse. That's certainly the easiest, the safest, the least expensive. Because if the problem is ovulation, then once you get a patient to ovulate, then you've restored natural fertility, which is like 25% per cycle. And in young patients, even if it takes 6 months, it's okay. But let's face it, we're all on a timeline, right? And we all want to get pregnant yesterday. And so I can't remember the last time I had a patient who did 6 IUIs before they went to IVF, right? That's a long time. And, you know, we know patients are starting when they're older, and there could be a concomitant male factor, other things going on, right? So the IUI category of trying to conceive, I like to have PCOS patients do low dose oral medications and intercourse or IUI. And the reason for that is 1 or 2 follicles, that's it. Because as after you go past 2 follicles, your multiple risk really increases. But there's a whole subset of patients who don't get pregnant with three sets or 3 tries of oral meds. And they're like, I'm not ready for IVF. What do I do next? So there's this middle category called injectable IUI. And that's a really tricky one for PCOs, because much like, and we'll talk about IVF in a second, when you start using recombinant FSH or injectables on PCOS patients, they're super brittle because they have very high fertility levels, but they don't ovulate properly. So they have tons of eggs that are ready to go, and you give them a whiff of gonadotropins or FSH, and they do nothing. Like you go 7, 10 days, nothing's happening, no ovulation. Then you go up by like a teeny bit, and there's all of a sudden 7 follicles. So you have to be really careful as you go more aggressive into the second category. So a lot of people won't even do gonadotropin IUI. I'm a little bit more flexible after you've been doing this for a while. Like, you know, the tricks and the tools overlapping with oral meds. You can try to sort of mess around so that you only get 2 follicles. You can convert to IVF. So you can play around with the injectables, but be very wary and go slow and go up on dosing very carefully. So IVF. So many PCOS patients need IVF, and there's lots of reasons for it. One is just they don't want to keep doing IUI. It's not working. It's only a 15% success rate, right? They don't want to do injectables because that's going to increase their twin and triplet rate, and that's terrifying for most people. So IVF makes sense. So same thing with IVF. You do not necessarily need a huge dose of meds, although it's tricky because if you have a high BMI, but also high fertility, you might need higher doses of drugs. So PCOS gets very tricky when it comes to fertility with respect to IVF. Most people will say you only need recombinant FSH and no LH, but that also has some variability, especially if you're higher BMI or you're a resistant PCO. We will add some LH depending on the protocol. But again, risk is that you hyper respond. And as you mentioned, Joy, the risk of OHSS. So PCOS patients with ovarian stimulation tend to have very high estrogen levels, multiple ovarian follicles. And so how do we mitigate that risk? Because really these days we want to have OHSS free clinics, and that's really doable right now. So our labs are really great. The sweet spot for number of eggs is 15 to 25 eggs. You do not need to get 90 eggs. So in fact, that's dangerous. So 15 to 25 eggs is the sweet spot. Titrate your dosing. We use something called an agonist trigger, which is a GnRH agonist without HCG, which really reduces the risk of OHSS. We adopt what's called a freeze-all strategy, where we freeze all the embryos, regardless of if a patient is doing genetic testing. By putting back an embryo, you increase the risk of OHSS significantly, and freezing embryos is completely fine. Monitor the patient after egg retrieval for signs and symptoms of OHSS, give them additional meds if necessary, and it's very doable safely. And listen, like I have a lot of PCO patients who come to me in like phase 1, so not ready to conceive, want to manage their PCO, and they're 32 years old. And so in the same conversation, I broach egg freezing because I'm like, you're 32, you're trying to manage your PCO, you're trying to like build your career, or you're in school, you're also trying to maybe find a partner, and that's a lot. So, and you know, you might have fertility difficulties, or you probably will later because you have PCO, perfect opportunity to freeze your eggs. And so, yeah, a lot of PCOS patients are sort of doing the management and treatment at the same time.
That's such a great point, because you're really freezing your eggs in time, right?
Correct.
So it's a great point for anybody,
Yes, PCOS or otherwise.
Yes.
But I think, you know, now, and I've been telling patients this recently, like the whole narrative has changed. Like before we used to say, you have to be actually documented infertile before you see a fertility doctor's. But now the narrative has changed. Like you can see a fertility doctor anytime because you have weird symptoms that could be PCO or endometriosis, because you just want a fertility check, because you want to egg freeze. Any of these reasons are legit to come see us.
And I think this is a huge change for, it's going to be a huge change for people in terms of getting ahead of infertility. Maybe you go when you're not ready to necessarily conceive, but if you feel like something's wrong or you just want a fertility check, you might find out things earlier on, and you might mitigate some of the things that may happen later on in life. So it's actually such a good way to think about it. It might be preventative.
Well, I'd go one step further. Like, I think it's going to be like pap smears. You get your AMH and your antral follicle.
That would be fantastic, because now you have to pay for your AMH, but like, who cares? It's $90, guys. Like, you spend more than that on one takeout thing a month, and it could be saving you a lot of distress down the road. But the education, it's coming. Like, a lot of people are talking about it. It's definitely, you know, being spread, the awareness. But it's still not 100% out there where everybody knows this is something that you should be doing from the age of 21, maybe once every couple of years, right? And I think that's going to change the framework of infertility altogether.
You guys are doing it. You're living it. You're
for that.
Spreading the word. So really proud.
Very excited. Okay. So what if somebody comes to you and says, hi, I'm new. I think I have PCOS, but I'm not sure. What questions should they be asking you about PCOS?
Well, I think first is, do you have it? And like, even though patients will come to me and say, my doctor diagnosed me with PCOS, I'm always like, let me look at this with a new lens. And so, you know, asking them all the questions like, do you have high androgen symptoms? Do you have irregular cycles? Do you have difficulty losing weight? So on and so forth. And so if they fit the bill and the diagnosis, then it's, you know, they should be asking, okay, what testing are you going to order to confirm this? And the answer to that is a pelvic ultrasound, a transvaginal ultrasound to look at their ovarian morphology, some blood work, which includes insulin levels, an A1C, a hemoglobin A1C, an androgen panel looking at their testosterone, DHEA levels. I always do their cholesterol profile because many PCOS patients will have like low-grade hypercholesterolemia even early on.
Wow.
And then any other infertility testing if they are trying to conceive. And then, you know, it's really like, where are they in their reproductive life? Like right now, is it that they are trying to have some predictability with their menses and the high male hormone symptoms are just debilitating, which they quite frankly can be. And how do we manage those? And, you know, when patients talk to me, I kind of get a sense, like, are they like, I want to get rid of the hair and the acne like ASAP? Then you go straight to the meds, right? If they're more like, yeah, it bothers me a little bit, but I'm okay, like, then you could kind of go slower with the inositol and the supplements. And then there's that third layer, which is, do we put you on the birth control pill because you're not trying to conceive and you need some regularity with your cycles and preventing endometrial hyperplasia, which we'll do a biopsy if we're worried about it. Or are they trying to conceive? And so for patients, it's like, okay, so yes, I am trying to conceive. What does my success rate look like? And so if it's a woman who's under 30 who wants one child, we have sort of ample opportunity, if everything else looks normal, to do letrozole for 6 months. If it's someone who's 35 and says, I want 3 kids, that's where I'm going to talk more about IVF and banking extra embryos for future babies. And all throughout this, the lifestyle piece is important. Because remember, we've gotten good and probably can get any PCOS patient pregnant. But if your BMI is like 30 to 35 and you have prediabetes, yeah, okay, I can get you pregnant, but you're going to be at higher risk for gestational diabetes, gestational hypertension, a C-section, preterm labor, OB complications. So it is always best to try to maintain like an ideal body weight, like be as healthy as possible. And that brings me to my next piece, which is, is there a role for getting yourself into an optimal shape before you start trying to conceive? And that's like a little bit of a tricky situation. You got to talk to the patient because, for a 39-year-old, that might not be optimal. They're already 39. For a 32-year-old, it might be more reasonable, but there's ways around it. Like if you're a 39-year-old, you have PCO and you have a really high BMI and maybe high blood pressure, we could do IVF and freeze embryos. You could potentially like take a GLP receptor agonist like Ozempic, lose a bunch of weight, and then come back and start putting in those embryos. So I think as a patient, it's important to sort of talk about and have a holistic approach, right? Talk about the whole management, like all the different options and how this will affect not only your ability to conceive, but your whole entire pregnancy and your future.
So what role does insulin resistance play in PCOS, and what do you advise patients to do for that?
Yeah, I mean, insulin resistance is definitely a key component. I don't see it as much in the lean PCOs because they don't have the excess body weight that produces extra estrogen. Extra insulin. So it's more so in the overweight and obese patients. And oftentimes you'll see very young patients, even in their early 30s, who are pre-diabetic or have borderline hemoglobin A1Cs or even like florid diabetes. So insulin drives male hormone production. So it just is like a vicious cycle. But in and of itself, if you have insulin resistance and pre-diabetes or diabetes, that's a risk factor for bad quality embryos, miscarriage. And we actually say that if your hemoglobin A1C is over 7, you should not be conceiving because of the teratogenic risk. So I will often see PCOS patients, and as part of their screening, when we do their A1C comes back like 8.1 or 9. And so those patients, I say, stop, like go back to your family doctor. You have diabetes now. You need to correct that, bring your A1C down. And so what does that look like? Well, for the patients who actually have diabetes or prediabetes, often that means taking metformin. Sometimes they need to take Ozempic and take 3 months and then come back and be off it and try to conceive. But most of the time it's like metformin or a combination of metformin and insulin to really bring down those sugar levels and be sort of medically cleared to conceive. But in the population of patients that is PCO, but not with obvious insulin resistance, meaning they have normal A1Cs, maybe they have slightly higher insulin levels, and you give them letrozole for a couple cycles and then maybe even tricloman, and you're like, what the heck? They're not ovulating. Often that's because of their occult hyperinsulinemia that's sort of dragging these follicles in their early stage. And so by giving them something like metformin, although honestly now I start with inositol and I only add metformin if I really need it because metformin is not super well tolerated. It has lots of side effects. But there are resistant PCOs that have normal sugar levels that you need to add on the metformin, and that'll induce or help ovulation induction with Clomid and Femera.
Wow, okay. Okay, so veering off topic-ish a little bit, obviously PCOS can have a huge, like other fertility issues, can have a huge emotional side to it. Right. So what have you seen? How does PCOS affect mental health? And what would you say to patients who feel defeated or burnt out by having all these erratic symptoms of PCOS?
Yeah, it's not easy. And I completely commiserate because we're all busy. We live busy lives. We have our careers. We have everything happening. Some of us are caretakers for other family members. So to deal with all of this is like an additional layer. Mm-hmm. And often PCOS patients are young, right? And they're in this finding a partner stage. And it's difficult, right? Like it is important to sort of consider your physical appearance, your mental well-being when you're looking for a relationship. So that also becomes very tough. So I think whatever your infertility diagnosis is, it's important to have good support. Mm-hmm. And so whether that's your partner or it's your best friend or it's one of our fertility counselors or it's a community like you guys have, I think opening up the conversation and normalizing it and being able to talk about it is really important. And we're sort of breaking those barriers now, like by having these conversations, right? And for patients and people to just feel okay with talking about it and speaking about it as a medical condition that's super common. And I think that's happening now. So that's really great. But, rely on your support system. I think a lot of patients I've noticed, particularly in Canada, it's something I saw when I came here from the US, is a lot of patients have other care practitioners or other allied healthcare practitioners. And those people are often naturopaths. Sometimes they're counselors or psychologists. And these are people that really help outside of what I'm doing, right? Mm-hmm. And they also help with some of the more natural ways of managing your symptoms. And I think that's really important because it gives you control, right? And I think people need to have that control to be able to manage things. So yeah, I think rely on your whole network. Like, it's not just about your fertility doctor. I wish I could say I can provide 100% full circle care for total mental and physical and medical well-being, but I don't think I'm that perfect. So definitely there's other resources out there.
Yeah, and you made a good point. Like, support groups are so important, and Oasis has so many support groups, but also if you need support on a day-to-day basis, literally go on Google and type in PCOS support group, or go on Facebook and type in PCOS support group, and you'll find something like that, like a forum or something that you can join. You could have day-to-day support for your specific fertility issue or whatever you are dealing with. So,
and it wasn't like that long ago, like even a little bit of time ago, right? You couldn't find someone, you just had to internalize it. So yeah. I think we're in a great time right now where people are actually conversing.
We need to take advantage of that.
Yeah.
Thanks, Dr. Sharma.
So if someone feels dismissed by their doctor, what's your advice for self-advocacy?
Yeah, I mean, I think, look, like, I think patients now are savvy and smart, and they call us out all the time, right? Mm-hmm. So I'm actually happy when patients stop me and say, oh, I want to ask something else, or they advocate for themselves. I'm like, you do it. Like, ask me, please do. So I think, asking all your questions when you have your consult with your doctor. I'll tell you, many doctors are like myself. Like, I answer emails, like when patients send a note through the secretary or the nurses, like, I think that building that physician-patient relationship is so important for patients to stay with you. So, like, gone are the days where you call your doctor's office and you hear from them 3 weeks later, right? Like, that's just not acceptable. So, maintain that relationship with your clinic, your nurses. I can speak about the fertility world. If you email or call our office, you will hear back from myself or the nursing team for sure within 24 hours. So, if you have a question, no matter how simple or small you think it is, like, reach out to us. Like, I'm doing emails to patients like at 9 p.m. when they email about something, because I know how important and burning it is to them. But the other thing I would say is, like, get another opinion, right? Like, I have no problem with that. If it's my patient or patients coming to me, like, this is an important journey. And I think things like PCOS, it's not something that you take one pill and it goes away. It's something that you have to live with for your lifetime, essentially. And so it's important to have a good relationship with the doctor you're dealing with. And so it might be two different doctors. It might be me during your fertility journey and then your family doctor, but you need to have good relationships with both. And I think, Marissa, really well, right? It would be wonderful if fertility was 1 month and done. A patient asked me today, oh, in the movies, like, you always see that the patients like have one night where they're together and they get pregnant. Like, how come that's not happening to me? And I was like, I would be out of a job if everyone could try once for one night and they would get pregnant. And I kind of wish that for all my patients, but that's not how it goes. So it can take a long time. So you want to partner with a patient and a clinic where you feel comfortable. You can ask questions. You can ask for a second opinion. Patients constantly come to me and they're like, hey, can we try this? Like, can we try this protocol? And within reason, like, we talk it out. We have a discussion. We're like, yeah, okay, let's try it, because, we're not robots. We're human, right? Yes. So some of this, especially in the fertility world, you don't know like you can look at all the data in the world, but every patient's individual and will respond differently. And so if it's not going to be medical malpractice, I'm like, sure, we could try that.
Yeah. Okay, so we have a few minutes left, and we want to make sure that we get to some of the questions that were submitted to be asked for you to answer. And if anybody has any questions, you can leave it in the comments wherever you're watching, and we will get it here. So I actually have a question, so I'm going to squeeze mine in there first. You mentioned hyperplasia.
Yes.
So if you're not getting a period, and you have hyperplasia, can you tell me a little bit, or tell us a little bit about what hyperplasia is and what can come from it? And then if you have PCOS and you don't have a period, but you also have Asherman's, can hyperplasia still exist in that environment? That was like a 7-part question.
Yeah, no, 2 complicated questions. But let's first start and break down hyperplasia. Like endometrial hyperplasia is a scary thing, and it's a precancerous lesion. And it does occur more frequently in PCOS patients, especially those who have very long periods of time where they don't get a period, more often so in the higher BMI patients and those with really heavy bleeding because they have these anovulatory cycles. But the majority of PCOS patients don't have hyperplasia. So it's not like everyone on this, chat should run to get an endometrial biopsy. So typically those are the kinds of patients that are at risk. And so when they come in and do an ultrasound, their lining is like super thick, like 21, 22, 23 millimeters. And you're like, okay, I got to biopsy this person. Their lining's all cystic. You biopsy them and it shows precancerous lesions. This is not cancer, typically precancer, and there's stages of precancer, much like cervical dysplasia. There's like it's not low grade, but it's called like atypical hyperplasia or simple hyperplasia. Then there's simple hyperplasia with atypia, complex hyperplasia, and complex hyperplasia with atypia. Any of those, and even stage 1 endometrial cancer, can be managed with fertility sparing therapy, which is progestin. And so some sort of progesterone or progesterone IUD or Megace, which is a high dose progesterone, can revert the endometrial hyperplasia, but you can't get pregnant, at least not in your uterus, while you have it. So many patients will be treated for 3 to 6 to 9 months, and then hopefully it reverts. Many patients will create embryos through IVF, have them frozen, and then when the endometrial hyperplasia is gone, we'll transfer an embryo. So that is endometrial hyperplasia. But if you are a PCOS patient who has a higher BMI, is getting periods only like once every 4 to 6 months, and when you get them, they're super heavy, an endometrial biopsy would be great to rule out hyperplasia. Your second question about Asherman's and endometrial hyperplasia, it's kind of like an oxymoron because Asherman's in and of itself means the lack of endometrial tissue because the endometrial tissue is replaced by scar tissue. So your periods are light and there's very little endometrial tissue. Yes, in that very little endometrial tissue, could you get endometrial hyperplasia? Yeah, it's very possible, but I can't remember the last time I've seen it.
Got it. Okay. We actually have some people asking questions.
Sure.
So somebody said, I've read PCOS can be a superpower for egg retrievals. What are your thoughts? I'm 39 and got 33 eggs out.
Yeah, that sounds like
ties into one of the questions that were submitted, which is, does having PCOS mean my egg quality is worse, even though I have more eggs? So maybe.
Yeah. So, I mean, sometimes it is a blessing in disguise, especially for women who are over 37, I would say, because 37 to 42-year-olds often have low AMHs and low egg counts. And so if you have PCOS, oftentimes you're blessed with a higher AMH and a higher egg count. So you tend to do better than the average 37 to 39 to 42-year-old. So I guess in some ways you could call it a superpower because you will make more eggs. It's not at all typical for a 39-year-old to make 33 eggs. However, you're absolutely right. Like when you stimulate and make so many eggs, you're going to have eggs in varying stages. And so PCOS classically, you'll have what's called 2 cohorts. So you have like this group of eggs that grows, and then you have this whole middle category of eggs that's like 12 to 15 millimeters. And if you wait for those smaller eggs to grow, the bigger eggs get too big and they're not going to be as healthy. So somehow you have to find that balance where the sweet spot is like 15 good eggs, but it's very classic for PCOS patients to get 33 eggs. Wow, but only 20 will be mature. And like 14 will fertilize and you'll still end up with 5 blasts. And you're like, how did I get only 5 embryos from 33 eggs? But that's a combination of quality and varying maturity. But yes, overall, it is a bit of a superpower when it comes to being an older patient and having a higher AMH than usual.
Okay, and then one last question we just got submitted. Can having PCOS predispose someone to hypothyroidism as well?
So PCOS and hypothyroidism, or any thyroid disorder, are both medical endocrinopathies. So they all refer to the endocrine system, but in general, they don't necessarily go hand in hand. I would say the association is more so that both PCOS and hypothyroidism are incredibly common in the reproductive age population. And so because let's say 10 to 15% of patients have PCOS and 10 to 15% of patients have hypothyroidism, if not more, there is going to be some overlap, but there is not necessarily an association. Now, mind you, anyone who has irregular periods, you test them for both thyroid disease and PCOS. And so there's this whole spectrum of subclinical hypothyroidism, which is like borderline levels where patients are getting treated when they're conceiving. So again, that increases the number of people who have, quote, both.
Okay.
Okay. Is miscarriage more common with PCOS, and how do you lower the risk?
Yes. So great question. Yes, we do quote a higher miscarriage rate for PCOS patients. And that's not necessarily because their eggs are more genetically abnormal. It's more the environment. So you could have a perfectly normal egg, but if it's in an environment of high male hormones, high insulin, and high sugars, it has a higher degree of miscarriage. And that's probably why metformin does have class B evidence, which is fairly good evidence that it can reduce the miscarriage rate in PCOS patients. That doesn't mean every PCOS patient should be on metformin, but if you do have significant insulin resistance or previous miscarriage, it might not be a bad idea to be on it. So ways of preventing it are reducing your insulin resistance and keeping your sugars normal, reducing body weight because we know obesity is associated with miscarriage, progesterone supplementation to help the environment, and consideration for IVF and genetic testing of embryos so you know that at least your embryo going in is normal.
All right.
Great. So this has been such a powerful conversation. Thank you, Dr. Sharma, for sharing your expertise with us today. Where can people find you if they want to learn more or work with you?
Oh, thank you for offering that. So you can follow me on Instagram. My Instagram handle is Dr. Prati Sharma. So it's exactly as my name is here without the period. So Dr. Prati Sharma, no spaces and lowercase. So please follow me. I'm probably a little too good about answering Instagram messages from everyone who messages me. So I will often get messages from patients saying, here's my situation, and, you know, I'd be interested in a consult, and then I can hook you in with my assistant. But if you just wanted to email my assistant's name is Jasmine, Jasmin. It's pretty easy. Jasmine, Jasmin at createivf.com. One word, CREATE, IVF.com. If you email her, she's very used to getting emails from prospective patients saying, oh, I heard Dr. Sharma on a podcast or a webinar, or I just contacted her on Instagram. She's very she gets those messages all the time, and she will expedite and get you in for a consult. Please do follow me and message me on Instagram, and or call the office. Like if you call the office, you can always reach us as well, but usually social media or email is the best way. And finally, I would just say, since we're talking about PCOS, I always tell patients it's the best diagnosis to have in my clinic because it is completely treatable, manageable, and these patients, when managed appropriately, have the highest pregnancy rates.
That's so comforting for people to hear that, there's some things that we have no explanation for, like literally unexplained infertility. So it's good to know that this is something that could be mitigated if treated properly, which is great. Well, thank you for being so open to our community and extending your arm through the screen and saying, "Come to me in the office. I'll get you in." And just thank you so much for being here and sharing your expertise with us. As I mentioned before, we know you're so busy, and just having you here to share and answer all our questions. We're so honored to have you. So thank you so much.
Thank you guys. What you're doing here is great work, and I applaud you. So keep at it.
Thank you.
Thank
you.
To
everyone, thank you for watching and sending in your questions. If you found this helpful, please share it with someone who could benefit. Please do not forget, October 3rd is our comedy show in Barrie. So if you're in Barrie or you want to take a trip up to Barrie, there is a comedy show fundraiser. All proceeds go to Oasis, which is great. And we still have the journal for, I believe it's $5 shipping. And you get this beautiful journal on our website. So go to oasisfsn.com. And yeah, thank you guys for being here. Thank you for sharing with us, Joy.
Thanks for being here, and we'll see you next time on Fertility Village Live.
Bye, everybody.
Bye.